Hello doctors, you are preparing for NEET PG. I will discuss with you the ECG in patients with chest pain. This is a very old BMJ learning module which some pharma company provided to me, and I found these 3-4 cases very interesting, and they will make you very confident in dealing ECGs related problems. So today I will discuss the first case, and then I will try to complete this module within next 2-3 days. So let's begin. A 56-year-old woman is admitted with a 3-hour history of central chest tightness and breathlessness. She smokes 20 cigarettes a day. Her symptoms resolved on arrival in the emergency department without treatment. Her blood pressure is 140/86, pulse 75 and regular. Cardiovascular examination is normal. What is the most likely diagnosis? Acute inferior myocardial infarction, hyperkalemia, myopericarditis, or non-ST elevation acute coronary syndrome. This is the ECG. Now, the correct answer is D. It is non-ST elevation acute coronary syndrome. Now, I will discuss the case, how this choice is correct and others are not. A choice is acute inferior myocardial infarction. Inferior myocardial infarction will cause ST elevation in the inferior leads, that is 2, 3 and AVF, which are normal, and this elevation is not there. Second is hyperkalemia. Hyperkalemia may cause abnormalities of the T waves. This will typically be tall tented T waves. In extreme disturbance, it will cause QRS widening or even a sinusoidal pattern. Hyperkalemia does not cause chest pain. So hyperkalemia is not the right answer. Then C, myopericarditis. Myopericarditis may cause a range of ECG abnormalities, including sinus tachycardia or other arrhythmias, prolonged QT or QRS interval, ST depression or elevation, and T wave inversion. The clinical picture here suggests a more acute problem. So it is ruled out. Now the choice number D, non-ST elevation acute coronary syndrome. This woman's history is in keeping with an acute coronary event. Her ECG appearance with deep arrowhead T waves inversion in the pericardial leads V1 to V4 is suggestive of a lesion in the proximal part of the left anterior descending artery. This may have already caused infarction. There are also STT wave changes in the inferior leads. Other suggestive findings would be ST depression, especially where it is dynamic, coming and going with pain, or ventricular arrhythmias associated with ST or T wave changes. Then, what is the optimal immediate management? A, arterial blood gas sampling, reassurance and controlled breathing. B, aspirin and thrombolysis. C, aspirin, heparin, clopidogrel, glycoprotein, class 2B and 3A, receptor antagonist, and admission for angiography, and non-steroidal anti-inflammatory medication and admission for observation. Aspirin and low molecular weight heparin. Now the correct answer is C. Arterial blood gas sampling, reassurance and controlled breathing. This is an inappropriate course of action since hyperventilation is unlikely to explain the severe ECG abnormalities and will delay treatment of her life-threatening coronary disease. Aspirin and thrombolysis. This is an inappropriate course of action because she does not have ECG criteria that would suggest benefit from thrombolysis. That is, new left bundle branch block more than 1 mm ST elevation in two contiguous limb leads or more than 2 mm ST elevation in two or more chest leads, or a true posterior myocardial infarction. Then aspirin, heparin, clopidogrel, glycoprotein, class 2B 3A receptor antagonist, and admission for angiography. This woman has a high risk of acute coronary syndrome since this is in part due to platelet rich thrombus deposition on a ruptured coronary plaque. Antiplatelet therapy is indicated with prompt inpatient angiography to treat, where possible, the underlying lesion by percutaneous coronary intervention. Non-steroidal anti-inflammatory medication and admission for observation. This is an inappropriate course of action. Aspirin and low molecular weight heparin. This is inadequate in light of the severe ECG changes. Now, learning by it. Percutaneous coronary intervention is the most effective single treatment for acute myocardial infarction complicated with cardiogenic shock. Key points. Deep anterior T wave inversion suggests a critical proximal lesion in the left anterior descending artery. Patients with acute coronary syndrome with marked T wave changes or dynamic ST depression are high risk and should be aggressively managed. Hope this case will enlighten you. You give your suggestions, and in the next video I will deal with the next chest pain scenario. Clinical tip: you should discuss patients like this with senior cardiology colleagues.